Again, thank you. I hope everyone enjoyed lunch,
Right.
and it's a great opportunity to
That's how my
meet such a fascinating group of people that we have here today. It's going to be a wonderful uh, 2 days together. We bring people from a huge range of disciplines and backgrounds, and I've really enjoyed sort of mingling and talking to as many people as I could. Wasn't that a terrific morning session? We went a little over time, but I was really impressed. I didn't want to interrupt the conversation. It was going so well. We're really grateful to Dr. Pearl, who flew in from California. I want to give a shout out to the folks that flew in from across the Atlantic, Charlotte and Susie from Netherlands and the UK. And we have folks from Boston, folks from Providence, Rhode Island, all came to the sweetest place on earth. I hope you guys had something that was chocolate today. There's Hershey Kisses. Okay, right. If you stayed in the lodge, your shampoo it really was chocolate. There's cocoa butter in it. When in Rome, is. And there's so much great lore about Milton S. and this town, and how he got the town through the Depression, how he came here. He made $1 million with caramels in Philadelphia. Back then, $1 million was a lot of money. He was one of the richest people in America, and he decided that caramel was a passing fad, and he came here where he grew up because he knew there were a lot of cows, because he had this idea for mass-producing milk chocolate. And before Hershey, chocolate was so expensive that it was really something that the average person never really got to enjoy. He democratized chocolate. And it was a company town, and pretty much everyone in town worked for him. And if he'd have his driver, drive around town, he'd look around, and if he didn't like how your lawn looked, you would get called into the office. So he was a little controlling. So there are some parallels between the president and Milton Hershey. For those of you who watch the Apple TV Plus show Severance, there are parallels between Milton Hershey and Keir. we all serve Keir. So, but anyway, big thanks to Milton for giving us this wonderful venue to have our conference, and for all of us who are here at Penn State Health are all here because of him, because he founded the medical school, and he brought me here from California. I was born at a Kaiser hospital, so Dr. Pearl was not CEO at that time. He came on a little bit later, but a lot of us are here from far and wide. Really comes back to Milton. So I thought we had a very good opening session. We covered a lot about the basics of human factors, artificial intelligence, what it can do. And I think that a couple of sort of overarching points that are worth making is AI is not going to be some kind of module that we plug into healthcare. It's not really like the electronic medical record that tried to replace the paper medical record. Sort of digitizing something that was already there. It's something entirely new. And it's not going to replace the doctor, it's not going to replace the care coordinator, but it's going to upend the entire system. For this to work right, we need to reinvent our healthcare systems so they maximize the strengths of AI and maximize the strengths of the human. And that means we have to get that human AI symbiosis right. And if we don't, things are not going to end well for us. So that's really what this conference is about, and that's why the human factors, the socio-technical aspect of thinking, that systems engineering, AI, and quality and safety really belong together. And it seemed like a little bit of a harebrained scheme to write a grant mishmashing those three things together that seemed so different, but the reviewers agreed that they really did belong together, and here we are. So thanks again to AHRQ, and thanks to all of our wonderful sponsors who, among other things, made your registration fee really inexpensive. So, basically, just a little less than the cost of the food, because of course the grant doesn't pay for that, but our sponsors did. So thank you so much, and to everyone. So one of the things that happened for the last 2 days is a group of the faculty and a couple of others who are AI researchers, human factors experts, quality and safety experts, all got together in a small windowless room 4 miles from here. And for 2 marathon days, we talked about a lot of stuff. And so we're here to quickly brief you on the output of the Research Summit, which was the first half of this experience. And I'd like to introduce Dr. Emily Patterson. You've already seen her name and face. She's one of the top 2 Pattersons that were mentioned this morning.
So thank you. Human Factors PhD engineer, Ohio State University and the College of Medicine. And I had the joy of being completely exhausted after 2 days. I think I worked until I slept both nights. It was really a wonderful 2 days. And as you might expect, a lot of what we learned and discussed sort of builds upon what we already know as a country. And so Jiajie Zhang has a usability and usefulness framework for electronic health records where he talks about the EHR as designed and the EHR as implemented. So in the AI as designed space, we talked about a knowledge gap being how do we have safe and effective AI where we have methods to develop, validate, and do post-market surveillance maintenance activities, which are essentially an evolution of an existing framework for FDA medical devices, and thinks about what's unique and special. And as with the keynote speaker, we don't think AI covers anything. We think there's lots of things it covers, lots of different technologies, and all of them probably need slightly different perspectives on them. The second theme as sort of the EHR as implemented idea, which is not in the FDA frameworks, is thinking about how can health systems make safe and effective AI from their perspective. And one of the possibilities at the state level for governance might be an add-on to an FDA that thinks about enterprise governance for health systems. So what health systems are AI ready? You know, what health systems are not AI ready? What are the kinds of questions that we can help the vendors to ask the health systems to ask the vendors to see whether or not they're ready to safely deploy? And if they're not ready to safely deploy, how can we help them? So how can we spread the expertise that's needed to know how to make sure a model fits your health system, patient parameters, image parameters? If the camera's too far away, then the image won't work. Do not use adult models for pediatrics. Just some things that we need to help people avoid. And then let's also think about, can we build onto existing HIPAA requirements, Joint Commission requirements in the sort of policy space where we don't have to create a whole new thing, but maybe we can add into sort of existing areas where we add AI into wherever IT is already in places, because AI is not really different than IT. It's just changing its capabilities a little. And then we talked a lot about the trade-off between innovation and standardization. And one of the things that we all kind of collectively came to is there are enough risks in this space that all AI will never get into a single hospital unless there's actually some regulatory help. And so the right dosed regulations thinking about not blocking innovation, but helping to standardize enough that we don't want like 3,000 things that don't interact that maybe some electronic health record vendor will buy and then not deploy on purpose. So how do we get this stuff in through some kind of right dosed regulation? We're not sure we have the answer, but that's where we ended up with, was lightly endorsing some form. And then we also had identified 3 use cases. One is radiology. The vast majority of ready-to-go clinical use systems are image readers. Radiology is a great area for that. We have some interesting ways beyond just reading an image. And then we talked about patient-provider communication support, things like chatbots and do we want automated replies without people involved, and various thoughts on those lines. And then we talked about sort of care coordination support. And the specific use case I want to pull out is someone in the ED consulting a surgeon to have an image created. It is not uncommon to have that request go through with literally no description of why. And so then the image gets delayed because they have no idea why the surgeon has to know why they're ordering the image, for what reason. That's an area where ambient communication can auto-generate an explanation for you. So that's what I had to share, and Kristen will tell you some more.
Good afternoon, everyone. Kristen Miller. I am the scientific director of the MedStar Health National Center for Human Factors in Healthcare, which is the largest human factors team embedded in the healthcare system. But you will hear more about that tomorrow. It was a lovely 2 days, and spending time with like-minded people, complementary disciplines, but like-minded in terms of this is a very practical, pragmatic thing, and we can talk about the academic components, but this is here, and we need to really think about sort of the implementation pieces. So building off of what Emily had said, I think one big concept is making sure that we have the same shared mental model in terms of concepts and definitions. And I think it was within the first, 15, 20 minutes of the first day where we were saying Chat GPT, and Josh, I think it was you that said, do you mean Kleenex or do you mean tissues? Right, and like I am certainly guilty of that, and it might seem nuanced, but it's an important distinction, and we want to make sure that we get ahead of that. I think so much of a human factors like healthcare person is me helping give people the language for things that they already know, they just can't articulate, right? Like, this thing is bad, I don't know why, and we help them understand, like, well, the usability or the heuristics or whatever it is. And I think a lot of those things came up in the summit as well. So we're talking about fits list and allocation of function, and that's what are humans good at, what are computers good at, but making sure that we have like that scientific rigor around those words, and drift and de-skilling and all of these things that are concerns, we can wrap around some of that more academic language. I think there are a ton of parallels to other places where we have applied human factors in medical devices, in new implementations of just like interventions and policies and procedures in the EHR. I think AI is very different, and we recognize that, but there's still the same process of design development, implementation, evaluation, post-market surveillance. And I think human factors has a role in each of those for AI. And so we talked about sort of this multiple places where we can infuse that human factors lens. And then I think the last thing is, again, just going back to this practical, pragmatic piece. We have to talk about financial incentives and limitations. We have to talk about culture and strategy. And we can't sort of avoid those topics because they are the things that are driving decisions that are being made. So how do we help navigate those components as well? Yeah, all right.
Thanks. So we had a great 2 days talking about these things, but that conversation isn't over, and we're hoping that we're going to hear from all of you. What do you think are the needs? What should the research agenda be for the next 5 to 7 years in this field? And by this field, I don't mean human factors, I don't mean AI, I don't mean quality and safety, I mean the combined field, the new field that merges all three of those. What do you feel the knowledge gaps are? And I hope to hear from many of you. We'll have an open mic session at the end of the next 3 talks. And the fun part comes at the end. We'll always save the best for last. Starting at 4 o'clock, we'll have our small group sessions. We'll be able to talk about an aspect of this in detail. I hope at least most of you will be able to stay. You might get done before 5:30, but I think we'll probably end up spending at least 45 minutes to an hour just to be able to discuss those. Most the group 1, group 2 both have about 30 people, and group 3 is a little smaller. So they may get done faster, but